Ma'am, you can start the meeting, ma'am.
Yeah, good evening, everybody. We welcome you to the SFM quarterly meeting of Delhi chapter. The topic which we have selected today is navigating conundrums of invasive procedures. This is the part one of this webinar. Invasive procedures itself is a very, huge topic. Not only does it include the diagnostic procedures, but we also have many interventions which are done. And today we have selected a few topics, one of which is invasive procedures in multiple pregnancies, which is a panel discussion, and then we'll have a crosstalk. We have the honor of having three experts who need no introduction on this platform. We welcome Dr. Ashok Khurana, who's the Professor Emeritus of Society of Fetal Medicine. We also have the honor of having Dr. Kaval Gujral, who's the lead of maternal medicine in Gangaram Hospital and is the ex-president of Society of Fetal Medicine, Delhi chapter. And we have none other than Dr. Ratnapuri, who's the most popular geneticist of the country and is also leading the genetic center of Sir Gangaram Hospital. I take this opportunity to welcome Dr. Alok Varshne also, who's the secretary of the new team just installed. And of course, Dr. Vatsala is the president who is going to lead the panel today. And without wasting any more time, I will like to first introduce Dr. Vatsala Dadwal, who's the lead of maternal fetal medicine at All India Institute of Medical Sciences and is a very dear friend to me. And it is a great pleasure to invite Dr. Anubhuti Rana, also as a panelist, who is also a part of the maternal fetal medicine team at All India Institute of Medical Sciences, New Delhi. And I'm so proud of her. She was none other than our student, our postgraduate student at Maulana Azad Medical College. For panelists, we have Dr. Vandana Chadda, who's running the Satwa Center, her own center of fetal medicine care at South Delhi. We also have Dr. Reema Bhatt, who's the lead of fetal medicine at this Amrita Institute of Medical Sciences, Faridabad. It is my pleasure to invite Dr. Sumitra Bachani, who is running the fetal medicine services at Safdarjung Hospital. And we have another very, very popular geneticist with us, Dr. Seema Thakur in this panel, who is running her own center in West Delhi. And with that, I hand over to Dr. Vatsala Dadwal and Dr. Anubhuti Rana for the panel discussion.
Thank you, Dr. Sangeeta, and good evening, everyone. We would start with the panel, and since everyone has been introduced, I'll just start with my slides. So we will be talking about invasive procedures in multiple pregnancies. So when we say so the panelists have already been introduced and Anubhuti would be sort of moderating with me, this panel. So multiple pregnancy is not always a good thing. It's only good when you have a good outcome and you hand over the babies to the mother. But navigating through the pregnancy, there are a lot of issues of prematurity, issues of prenatal diagnosis, other issues, how to optimize the pregnancy, you may do fetal reduction, without which there is a higher risk of neonatal deaths and postnatal deaths and preterm deliveries. One of the major problem with the multiple pregnancies. So to start with the first case, there is a 36-year-old lady who's second gravida with one living issue at 13 weeks period of gestation. And she had her first trimester scan done, which showed her diamniotic dichorionic twins. And rest of the NT was normal and there was no anomalies. But she had an NIPT done because she's 36 years old and it was high risk for trisomy 21. So she has come to you, Dr. Reema. What would you do next for her?
Thank you, Dr. Vatsala. So I have a patient who is a dichorionic diamniotic twin pregnancy with a screen positive on NIPT. Now, this patient certainly deserves invasive testing. And in twins, chorionic villus sampling is a very safe option if I have to offer my patient. So the most important thing for me to do would be mapping of these
So
babies.
just so you counsel the patient and they want
Yeah,
an CVS. So
yes.
then could you just tell us like how would you go about it? When would the procedure be done? And if you could just give a checklist, what you should check
Okay.
before proceeding, and how do you counsel your patient? And again, like you've
Yes.
already talking about the mapping and a bit about the technique of sampling.
Yes. So my patient has consented for sampling. So one important thing is to tell her about the pre-procedure checklist is very important, which would be pre-procedure counseling. That is very important. Secondly, I need to know her RH status, whether she's RH positive or she's RH negative. There's a lot of counseling that goes about the procedure loss, which could be about 0.1 to 0.5% what we counsel our patient. And also the turnaround time for the tests that are expected to come. All this needs to be told before we begin our procedure. Then would be the ultrasound. After the patient has consented, we need to confirm the cardiac activity. The indication also, we need to be very sure of what we are asking. So here we are sure that NIPT is positive and we need to offer her. We need to confirm the CRL. So our patient should be in the period of gestation where chorionic villus sampling is feasible. And of course, it would be better if we know the HIV and the HbSAg status of the patient. So once we've confirmed that it is a dichorionic diamniotic, everything else is fine. Her blood group is known. She's consented to it. She knows about how the test is going to be performed. We map the placenta well. Now, this mapping is important because we need to label the twin A and B. The one that is closer to the cervix would be A. The one above would be B. Or if it's right and left, then the twin A would be on the maternal right with the and the one on the left would be twin B. So once we've done that, it is extremely important that placentas are marked. We've drawn a diagram where we know that this is fetus A, this is fetus B, the location of the placenta we have to be very, very sure of, which is the most crucial step, is planning and mapping of the placentas in the twin pregnancy. So we need to be very sure of that. Suppose now these placentas are fused. In that case, the tip of our needle should be very close, should be close to the insertion of the umbilical cord or should be at the placental margin. The possibility of contamination, cross-contamination of the sample in a twin pregnancy is very high. So this is something that we should always have in our mind. So sampling has to be very adequate. And for that, we have to be very sure of the mapping that we've done for our placentas.
Rightly said, Dr. Ima, just a little small snippet. So this is a dichorionic pregnancy. We can see the lambda sign. And here, like the placentas are separate, anterior and posterior. So we can easily access them separately. But again, not to underscore the importance of labeling the twins. It's not only like maternal side, we should also trace the placenta and also how much bladder was filled when we did the scan, because empty bladder or full bladder can also change the position. So it's very important that we properly label the twins. So once we sample, then we use another needle to sample the other sac, which you can see here. So we have sampled the other sac. So like Dr. Rima was saying, like if we have a pregnancy where it is a fused placenta, we can see it's a dichorionic pregnancy, but the placenta is one. So we are going towards the two edges of the placenta to sample. So here is somewhere is a dividing membrane. We're accessing this placenta from here to take one sample. That is the dividing membrane over here. And then we go on the other side. From the other edge, we take the sample so that we don't contaminate and we don't sample the same twin twice. So this we have to be very careful. So a little bit about the post-procedure care. So we have done the sample, we have got a sample. How do we counsel our patients? Dr. Sumitra?
Yes. So, good evening. So post-procedure, one thing is very important that we should of course be able to document that we have taken enough sample, and minimum should be around 4 to 5 milligrams of sample should be there. So we can separate that out, see it in the Petri dish, and confirm that we have taken an adequate sample. Also, we should be able to show the cardiac activity to the patient herself, and reassure her that both the cardiac activities are there. And after that, of course, we have to document all the findings and make a diagram also as to which fetus, which placenta, as ma'am you've already shared, and tell the patient. So it is optional. We here at our institute, we do give a shot of antibiotic, and tocolysis need not be given, but the patient should be told that she should limit her physical activity. She should not do any strenuous activity for next 24 hours. If she is Rh negative, then of course within 72 hours she should also receive the anti-D prophylaxis. And she can be told about the turnaround time of the test, and when she needs to come back with the report for the post-test counseling. She
Also,
may
like-
have little spotting after a CVS sampling, so she can be reassured that a minimal amount of spotting may be there.
So she may have a little bit of cramping, pain, spotting, but if she has bleeding or she has fever, any other symptom or any leaking, she should report. So, Dr. Vandana, what are the complications if when you're doing CVS in multiple pregnancy? Is it the same, or these are different or higher than the singletons? Dr. Vandana, I can't hear you.
Am I audible now?
Yes.
So we've already discussed that in twin pregnancies, we have to put in the needle twice. So as expected, you might, get the number of all the complications that you get in the singleton CVS, you will get all of those and maybe a bit more. The risk of pregnancy loss, the data is a little bit contradictory, but still I would say it is higher in twins compared to a singleton CVS and could approach as high as 1%. If it was 1 in 200, say in twins, it will be a 1 in 100 for the twins, then it will be 1 in 200 for the singletons. And of course, the complications would depend upon whether the number of times you've pricked or the possibility that you've used a transvaginal approach for one of the twins, because you could approach it from the top, or the the person who was operating was not that experienced in terms of deciding how to approach and had to prick many times. So all of those things. Now, all the complications like bleeding, leaking, rupture of membranes, or a chorionitis could happen. If you've done it too early on, we know that after 11 weeks, it's not so common, but if you do it before 10 weeks or so, you may end up with something called a limb reduction defect or a mandibular hypogenesis. So one worries about those things. Now, I would also say in twins, there would be a higher risk of cross-contamination with the other twin, because you may, when you are approaching, you may inadvertently take in some of the sample of the twin by going through placenta. So, you need to have all the tricks of the trade in terms of how not to contaminate or cross-contaminate one twin with the other, or contaminate one twin with the maternal contaminant. I would say the MCC would also be higher for twins. So,
So, I mean, we usually do transabdominal approach. So, like, I would just like to ask the panelists, do you use the transcervical approach, or you're all doing transabdominally, CVS?
Personally, I have also never used a cervical approach for the last 20 years. But I would say never, because in say a triplet, or sometimes very rarely the twins, that thought does cross our mind when it's almost impossible to get through to the other placenta without touching the top one. If it's a very posterior placenta and both the placentas are posterior, it's sometimes very hard.
Okay, thank you. So again, like Dr. Vandana said, like the data about fetal loss is a little not too clear, but we can say approximately 1% risk of fetal loss. Although a recent study said that there is no increase over the background loss of twins, but I think it's always better to counsel a patient saying that there is a 1% risk. So there may be risk of sampling errors. So Dr. Seema, can you tell us how would you ensure that we have not got the same sample twice? or there is, how do we rule out maternal contamination?
Yeah, so first of all, the first question asked by me for me is that how much sample is adequate in the chorionic villus sampling. So generally, as per the literature, it is about 30 to 40 milligram of the CVS chorionic villi is required for the adequate reporting of the genetic test. So how do we assure in a clinical practice 30 to 40 milligram? No one has the weighing scale, and most of us don't have the microscope. So generally, I would say that if you have a the lung tube, the conical portion, so at least in the conical portion, probably 1/10 of that, if there are a white chorionic villi thread-like structures, so that suffices. Then the most important part, which is the maternal cell contamination exclusion, and that is generally dealt with the maternal cell contamination by the VNTR analysis, where we match the fetal sample with the maternal and try to find out the DNA polymer by the DNA polymorphism, whether it is of the same mother, and whether they are, if they are of the same, types, then probably then we may say that there is been the cross contamination between the two samples, and the lab may ask us to repeat the samples. And this happens. This is not that theoretical. Sometimes we have also faced these issues that the samples the lab receives, they are not very sure that these are from two different tissues, two different samples, and then we have to repeat the samples in such situations.
Thank you. So just we move forward, like if you don't get a sample, then what we should do, and if we find confined placental mosaicism, how should we approach?
Yeah, if we don't obtain any sample, then it's better to wait for about a week to repeat the procedure, because doing back to back may increase the chances of abortion. And in cases of the confined placental mosaicism, this means that the genetic disorder, the aneuploidy, is restricted to the placenta, and this may happen in about 1% of the cases. And in those situations, if the ultrasound is all normal, then we will only get to know that this is a confined placental mosaicism after doing the amniocentesis. So we need to resort to the amniocentesis to confirm the diagnosis of the confined placental mosaicism.
That's right. Thank you. And I think we need to counsel the patient about this possibility.
Yes,
that
they need to be aware before.
Right. So this is the second case, Dr. Anubhuti.
So this is a 35-year-old lady, a primary gravida at 17 weeks period of gestation. She had an NT-NB scan which was completely normal, showed a dichorionic twin, and now both partners have been screened with thalassemia trait, and the mutations have been identified in the couple. So I'd like to ask Dr. Sumitra, what procedure would you like to offer now?
Sorry, at what period of gestation is the pregnancy? 17
weeks. 17 weeks, dichorionic pregnancy, thalassemia mutations have been identified.
So at 17 weeks, we will offer amniocentesis. And since we have already identified the mutation, then we can do Sanger sequencing because the mutation is already identified. And for the procedure, to do the procedure itself, there is a pre-procedure checklist. I think the similar one as we've gone through for the chorionic villus sampling. And I need not share the details again. The important is to label the twins, and that we need to draw the diagram, and along with the placenta, either it is right or left. So maybe on the right, twin A would be right and twin B would be left, or it may even be upper and lower. Sometimes we find it that way. And if the bladder is full or empty, that needs to be documented. At that time, it may change the position of the twin. Now we can do two approaches. One is the double puncher. There is also a single puncher approach. But the single puncher approach I have not myself done, but the single puncher approach also carries with it the risk of doing a septostomy and making it a monoamniotic cavity. There is a risk of pseudo amniotic band formation also. And but with the double puncher technique, there is around 1.5% risk of sampling the same sac twice. So that needs to be kept in mind as to how it's also sometimes recommended that if we can do both together, but that is not feasible, of course. So one needs to be very careful and label the samples very carefully. Once we should be able to see the dividing membrane. That is most important. Once we
Yes.
see the dividing membrane, we can go on one side, take the sample, and then, keeping that dividing membrane, go on the other side and then take the other sample. First 2 ml is discarded to prevent maternal cell contamination, and the rest of the sample we would need around 18 to 20 ml, 18 ml minimum, depending on the type of test. Sometimes for a whole genome or multiple tests, the lab asks for a larger amount of the sample.
Yes, and this is the video in which it's clearly seen that we have to label first and then we have to take the sample on either side of the dividing membrane. And in dichorionic twins, it is important to sample both sacs. So, Dr. Sumitra, again, what would be the risk and complications of amniocentesis in multiple pregnancy?
Again, since it is again 2 times we are going to puncture the uterus, so it would be higher than a singleton, but exact risk, I could not come across the exact risk, how much risk would increase. But in the ECO guidelines, and you're also sharing here, that mostly the risk remains the same as in a singleton, but also in case of a singleton, in case of a twin which is not affected, we see a certain fetal loss rate. When we do amniocentesis, definitely the loss rate is higher. If the twin is affected for whatever reason we are doing, especially if there is maybe a structural anomaly or the NFT was thickened, if some anomalies they are perceived, there is some problem with the twin, then definitely the loss rate becomes higher than in case of an otherwise background risk which is there in a normal twin pregnancy.
And sometimes we often come across as patients who had rupture of membranes and present with leaking after amniocentesis. So what would be their optimal management and how would you counsel?
So prom after amniocentesis can occur in 1 to 2% cases. And mostly we've observed that there is spontaneous sealing in this, and we can offer them an expectant management. And most of these times, the outcome is better than if it would have otherwise occurred. Without amniocentesis in a otherwise spontaneous prom, the risk is higher of an adverse outcome than in such cases. So we can reassure the patient that the risk is lower than otherwise in a spontaneous.
And how will you follow up this patient?
So in this case, we need to follow up. One is that very, very rare chance of infection or chorioamnionitis, which is less than 0.1%. So we need to follow up with an ultrasound, and we in our institute, we do get a few blood counts also done. If the leak has persisted, then we need to see if, how much longer the leak has persisted, because in case there is a leak which is leading to a chance of infection, then we would have to think of termination. So that is one dilemma we can face, but mostly the outcomes are good, and we can follow with ultrasound and with the counts.
So rightly said, I would actually ask Dr. Reema some dilemmas regarding amniocentesis in multiple pregnancy. What about dry tap on amniocentesis?
Okay, so this is a possibility that we get a dry tap when the membranes we are not able to go through, and there is a possibility. But in that case, we definitely need to reinsert and we need to take the sample. That possibility will always be there. We need to be careful when we are entering. We have to enter with a jab. That is the technique. You can't be having nudgy movements. It has to be with a sharp jab. You dent the membrane and enter with a sharp jab. That's the way you will prevent a dry tap.
What would you do if the twins had one anterior, one posterior placenta? I think we've discussed this.
Yeah. So you have to go through the anterior placenta. If you don't get a pocket when you can enter without the placenta, you may have to take the thinnest part of the placenta, and that's the only option that we have.
And what about?
And if you have fibroids, yeah, so fibroids and obesity, we would always prefer to take a long needle, which is our planning, that is what I said, is very important. We plan that the distance is more, so the needle selection is important. It has to be a 15 centimeter or a 20 centimeter needle when we are entering with the mother who's obese or if there are fibroids.
Absolutely right. Yes, ma'am. And now, Dr. Vandana, I would like to further add to the dilemma. Amniocentesis to anterior placenta, we have covered that we want to go through the thin part maybe. What about if patient has a choriamniotic separation or a subchorionic hematoma?
So, I mean, we face situations where there's a massive subchorionic hematoma. In fact, some of these pregnancies, you may have very high beta HCGs in the quadruple test or the first trimester. So the false positive rates in these biochemical screens also goes up. And when you do the amnio, you'll typically see that brown colored amniotic fluid. So
Could we definitely
even
proceed?
in my anecdotal experience, there is a higher risk of pregnancy loss in these patients, and these patients need to be counseled. So unless the indication is an absolute indication to do the procedure, I would probably hesitate to do the procedure. And if I have to do it, if I must do it, then I'll counsel the patient in terms of the pregnancy loss being more.
Right, right.
Uh,
And Seema ma'am, what do we do if we have some discolored samples, hemorrhagic samples?
Yeah. So in cases of these discolored or hemorrhagic samples, there may be the error in the reporting. And this is basically because of the maternal cell contamination, which may, hide the mosaicism. That may be incorrect also because, we don't know which cells we are counting. So in all such situations, we need to do a backup culture, and the molecular test or the cytogenetic karyotype should be done on the cultured amniocytes. So the lab should be informed beforehand that they have to do because in the current trend is going throughout the molecular test only. So whenever any clinician faces this, because this is not uncommon, so whenever any clinician faces, they need to inform the lab immediately so that they keep a backup culture and do the testing from that only. And the patient also needs to be informed that these are the technical issues, and we may have later delayed reporting because of this.
Very true,
And also
ma'am.
the increased chances of abortion should be warned to them that in these cases.
Yes, ma'am. So now we move on to case 3, and she is a 26-year-old primary gravida conceived after assisted reproduction, presented at 12 weeks, 2 days with an NT&B scan showing monochorionic diamniotic twins. Rest of the NT&B is normal, and her combined screen is high risk for Down syndrome. So, Dr. Vandana, I would like to ask, what procedure would you offer? CVS or wait for amniocentesis, 17 weeks for amniocentesis? How would you proceed?
So in monochorionic twins, I would say that they share the placenta, and technically speaking or theoretically speaking, you can sample one placenta and get the karyotype of both the twins. But there's always that concept of having a heterokaryotype in monochorionic. So ideally, the procedure of choice is going to be when you sample each of the individual sacs and you get separate chromosomal analysis and separate results for both the monochorionics. So in a discordant monochorionic, that would definitely be the procedure of choice. And even here, I would say that is my first preference, to go in and sample separately.
So amnio or CVS?
I would say in MCDA twins, I would prefer amnio. And if there is a what is the, can we go into more details in terms of what was the positive, what was the ultrasound like?
The ultrasound is normal. Both the NTs are normal, nasal bones are present. There are no other markers of aneuploidy and ultrasound. She's a 26-year-old conceived after assisted reproduction.
Yeah, so there is a high risk for trisomy 21. So again, the choice between two procedures could be discussed with the patient, and in terms of the early procedure, you get an early result. But I would say if the ultrasound is normal, and I could even offer her NIPT in this situation. But if I have to do an invasive procedure, probably the amnio would be my first choice.
And how many sacs in amniocentesis?
Both the sacs, both are normal fetuses.
So they are not discordant for anything, no anomaly, no markers, no growth, no discordancy. You would want to sample both fetuses in
Yeah. In monochorionic, the test of choice would be separate samplings of both, and even if they are not discordant, but it could be a debatable issue in terms of which test to offer in this situation.
Yes, because there's a very rare possibility of discordant
Yeah,
chromosomal.
heterokaryotypy, yeah.
Yes, so it is how you counsel and the numbers you tell, right? So case 4, moving on to case 4, she's a 35-year-old primary gravida and she presents at 10 weeks, 3 days period of gestation. And this is the ultrasound showing a triplet, triamniotic, trichorionic pregnancy. So Dr. Sumitra, how can we optimize this pregnancy?
So we can counsel that triplets, of course, carries with it the risk of maternal as well as adverse maternal as well as fetal outcomes. More risk of GDM, preeclampsia, anemia, preterm labor for the mother, and preterm delivery, low birth weight, and of course, this is triamniotic trichorionic. So definitely there can be increased risk of preterm labor as well as fetal losses. So fetal loss would be around 5 to 6% fetal loss can be there. So we can counsel that we can reduce the amniotic trichorionic to DCDA twin, and because with each reduction we are improving the outcome by almost 2 to 3 weeks. We are increasing the period of gestation when the delivery would take place. So with that, we are definitely improving the fetal outcomes. So we can offer from triplet to twin. From triplet to singleton, again, the risk of abortion, like a risk of abortion with one reduction is around 5%. So triplet to twin, the risk of abortion would be higher. It would be around 6 to 7%. And though it will definitely improve the pregnancy outcome, but we'll have to weigh between the risk of abortion and the prolongation, the final outcomes. So
Yes,
that
risk
we'll
of
have to
preterm
counsel.
birth
And
decreases if you reduce it to singleton, but the risk of miscarriage is almost similar. So all that counseling and the patient's choice is most important. So moving on to the next question, when do we offer multifetal pregnancy reduction, Dr. Vandana?
There's this whole debate about early versus late reduction in the early first trimester versus late. So the advantage of doing that 11-week reduction is that you've given them optimal time to reduce if it may. And then when we look at them at the 11 weeks, we can do a very detailed anatomy scan. We can do our nuchals. We can look at all of these defects like limb body wall complex. We can look at acrania and all of those things. So we can optimize the anomaly scan so we don't leave an leave an anomalous fetus. And the pregnancy loss rates also in comparative studies have shown that it's the 11-week transabdominal procedure, because that's when we'll do the transabdominal versus the early reduction when you have to do the transvaginal approach, where the fetal losses are less. So the fetal loss definitely in all of the data that's come recently shows that the transabdominal procedure wins hands down. So I would say the 11-week transabdominal approach is the one which optimizes the outcomes.
So now we have this patient, and now Dr. Seema, which fetus would you like to select for fetal reduction?
Yeah, so that depends upon the results of the ultrasound. If the ultrasound is all normal for all the 3 fetuses are normal, then the usual approach is the one which is the closest to the maternal abdomen, that is selected for the fetal reduction.
Yes, and fetus above the cervix is generally avoided, or any fetus with a growth lag or malformation, as Dr. Vanna said, would be chosen for reduction.
Yes.
And Dr. Vanna, so how will you perform this reduction?
So we discussed before that it's the trans-abdominal approach which we want. So as you rightly said, we need to, all of the things that we need to checklist before the procedure, the most important would be the counseling. So I would say emphasize on the part that if you have triplets, there's high risk of preterm labor and what all risks are there in terms of prematurity to the couple. And so they make their choices. And then you do it as an outpatient procedure, as you've mentioned here. And we usually use the transabdominal approach, a freehand approach. We approach the thorax of the baby, ideally the fetal heart, and intracardiac KCL or intrathoracic KCL, 2 to 3 ml should be suffice to get the asystole. And the asystole usually comes within a few seconds. And once you've documented that, you can withdraw your needle. So the technique of intracardiac KCL is the preferred technique transabdominally.
Right. So in multichorionic, we can use intracardiac or intrathoracic KCL.
And as Dr. Seema has already mentioned, if all of the three are normal looking, then it's always the easiest to approach the one near the fundus.
Yes, yes. So Dr. Vandana, what about the post-procedure care and follow-up?
Yeah, so we can give the gram-positive antibiotic coverage, and as always, if the woman is RH negative, make sure you have the indirect Coombs test in hand and give the appropriate anti-D to the woman. And I don't think there's any risk of DIC per se, and we can give her a little bit of progesterone support, but that's also not, there's not much evidence for that also. We usually like to follow up at least once to see that the asystole that we've documented has stayed and there's no sort of the revival of the heart. That's a good practice. And also to see the other heartbeats and to show them to the couple.
So generally, we like to call them after 1 to 2 weeks for one follow-up also.
One follow-up, yeah.
So Dr. Reema, what would be the risk and complications in this procedure?
Yes, so the risks that we are expecting is abortion is a risk which we've already discussed. There's risk of bleeding, there's risk of infection, there's risk of chorioamnionitis. All these risks need to be explained to the mother before we go with the procedure. So all this can happen, and she can also go into preterm labor even before 24 weeks. The risk exists, and of course, intrauterine demise of the other twin is also a possibility. So all this needs to be counseled well.
Yes. Now, Dr. Sumitra, what would you do if there was a patient asked for reduction of twins to singletons?
So twins to singleton, that means selective reduction of one twin, definitely. If there is especially, so are you talking about monochorionic?
No, ma'am, multichorionic.
Okay.
Triamniotic, trichorionic. So we know that selective reduction we will offer if there's an anomaly or a genetic abnormality.
Yeah,
but what about everything is normal and she wants twins to singletons?
So only if we have a twin which has a certain anomaly which is going to affect the outcome of the pregnancy. So if there is, say, an anencephaly and there's going to be a big polyhydramnios there which is going to affect the outcome, then definitely, yes, we can go for reduction of that twin. And in case of a anomaly which is not as such not going to affect the outcome and which can be treated, may say it is a spinal dysraphism, something which can be treated after delivery, then I wouldn't counsel like from twin to singleton. Only thing is that the maternal risk of complications is more. So if the maternal morbidity is there, say in the case it is chronic hypertension, some heart disease where a twin pregnancy would have increase the morbidity of the mother. So those factors can be considered if you are looking for reduction. Otherwise, sometimes, very rarely, the patient herself would feel that she may not be able to bring up two babies. So I don't know if maternal desire for that reason, if one does, then that would be a very rare possibility.
Yes, that's a little bit of controversial. We do it generally for fetal and maternal indication. It might wish due to a social and psychological reason of the patient. So this is an area of controversy. So Dr. Seema, are there any contraindications for all these invasive procedures in multiple pregnancy?
Yeah, so whenever we do any procedure, we have to have again included all these things, that any maternal infection, even the use of anticoagulants also. Like many of them, these are IVF cases. So we realize that they may be on the ecosprin or the anticoagulant. So we have to take precautions accordingly. And the ecosprin needs to be stopped. The anticoagulant has to be bodylated. We can do, of course, the last the Clexane dose just prior to that. So all these precautions needs to be taken care in the pre-procedure checklist only.
Yes, very true. So we have to take care, and there's no absolute contraindication, but all of these are relative contraindications. Now we move to case 5.
So now we have a little more complicated case. So she's a primary gravida at 15 weeks and 6 days of gestation, and the ultrasound shows a dichorionic triamniotic triplets. And so scan has been done. One fetus has EICF, and fetus 2 and 3 have EICF and piloectasis. Fetus 2 and 3 are the monochorionic pair. So what are the options for her? The patient wants to know like how best she can optimize the outcome for her babies.
Ma'am, so now the options that are available, the best option I feel in clinical practice is to reduce the monochorionic pair and retain the singleton, because this gives best chance. We are anticipating complications like selective growth restriction, TTTS, in 10 to 15% of monochorionic twin pregnancies. So the best option would be retaining the singleton pregnancy. But in case we want to, the patient insists on continuing twins and wants to reduce one monochorionic pair, then the procedure is more complicated. We either need to resort to laser. Interstitial laser is an option at early gestation, or RFA, or bipolar coagulation. So here the risk of fetal loss definitely increases as compared to reducing the monochorionic pair. So it's a dilemma, and I think the patient needs to be counseled very well in taking this decision.
So definitely, compared to continuing with the dichorionic triamniotic pregnancy, reducing it to either twins, dichorionic diamniotic or monochorionic diamniotic will have a better outcome for her. And like Dr. Rima said, like it's better to make it a dichorionic diamniotic, because if you leave a monochorionic diamniotic pair, you have all the complications of a monochorionic pregnancy, and that could also affect the outcome. So we've had a couple of patients like this, but they said they want a twin pregnancy and they don't want a complication of monochorionic twins. So the patients can also be pretty demanding. So what would be the next step? How should we handle this patient, Dr. Vandana?
So, as we've already discussed, if you have to reduce the single baby, you can go ahead and do it with the intracardiac KCL. But if you have to reduce one of the monopairs, then you have to use a method like a laser or a RFA, so that you have to cut the cord between one of the twins.
So if you're doing a vaso-occlusive method, when should we do it?
So for the for the intracardiac KCL, we can do it anytime after 11 weeks, 12 weeks, and so on.
Yeah, like we have to reduce one of the monochorionic twins.
Yeah, so for the laser, we'll have to do it around the 15, 16 weeks, because we don't do it earlier. And if you have to reduce one of the monochorionic twins, then I would say around the 16 weeks would be an ideal time. Using you can use diode laser or RFA, either of those.
So again here, like we cannot use KCL for a monochorionic pair because of the anastomosis between the two placenta, between the twins to the monochorionic placenta. Because if you reduce one twin, the KCL can go to the other twin, and also like if one twin dies in utero, there's a risk of neurological damage of the other twin dying. So like rightly said, we can use an interstitial laser, RFA, or bipolar cord coagulation. And RFA gives a better, compared to interstitial laser, RFA is better and technically easier. So Dr. Vandana, would you just like to describe the procedure, like how we do it? You said we do it around after 16 weeks.
16 weeks. So for the interstitial laser, we usually use diode laser, and we start with 15 watts, and usually the heartbeat goes away after a few pulses. And radio frequency ablation is not something that I use frequently. I mostly use laser, but as you mentioned here in the slide, that you use a 15 centimeter long needle, and you use a radio frequency generator that produces a high frequency sinusoidal current, and that is that energy is used to stop the coagulate the vessel.
So right, like as in interstitial laser, RFA also we try to coagulate the intra-abdominal part of the umbilical cord.
Yeah, so the part where the umbilical artery is entering, and you have all the three, the artery and the vein in between, that's the area we usually target for the interstitial laser and the RFA.
So this is just a small video showing the entry of the RFA needle. So these are the triplets that we reduced recently. So one of the monochorionic pairs we reduced. So that is the needle, which is like we introduce into the abdomen of the fetus, where you have these umbilical vessel entering. So once we are in, then we open the tines and pass the current. alternating current, and this would ablate an area of around 2 centimeters. So we use like sort of 100 degrees current at 100 watts for 3 minutes. So here you see, like you can see the fetal, you could see the cardiac activity of the two twins, and there was severe bradycardia in the one that has been reduced. So, Dr. Rima, is any other technique that we can use for reducing monochorionic twins?
So yes, bipolar cord coagulation is an alternative that is available with us. The success rate is very good. It's comparable to RFA. So what we do is that it can be done by two methods. Either it is under ultrasound guidance that we can do, or we can do a fetoscopic bipolar cord coagulation. So the only thing is that the thermal effect is what is used. Normally, we use the power setting of 30 to 50 watts, and about 30 seconds is what is required. And this is exactly like we use a bipolar, that it causes coagulation. It performs as well as RFA. The only thing is the risk of PPROM goes a little higher with bipolar cord coagulation as compared to RFA. It goes to about 20 to 27%. So that's the only difference if RFA. Otherwise, it performs very well and it's a good technique. But if the cord can slip away, that's a technical glitch that happens while performing the procedure. So I think, ma'am, you're showing the procedure where you can see the entry of the bipolar, and the prongs of the bipolar are opened. When we enter inside, we need to enter in such a way that the prongs are visible. We hold the cord adequately, give it a little traction so that we know that the entire cord is in between the prongs and it's not slipping. And then, of course, the current is passed to ensure adequate coagulation, and the blood flow through the umbilical cord ceases. The cardiac activity may take a little time to stop after the procedure.
So which method is preferable, Dr. Sumitra?
So out of the three, interstitial lasers preferable in smaller ones, like around 16 weeks or so, 14, 16 weeks or even lesser, we can use intrafetal laser. Intrafetal laser doesn't work so well at a higher gestation. And RFA and bipolar, the outcomes are good, but RFA, I think, is better because in the bipolar, we have to catch hold of the cord. And so the cord may slip away. It may be a thick cord or a short cord. So there can be a problem using a bipolar. And also the need for the amount of like RFA we can do in a stuck twin, but in a would be tough. I haven't done with the bipolar in a stuck twin, but would be difficult to do with bipolar. So depending on the type of reduction, the fetus, the presence of the type of fetus, then the cord, as well as the presence of hydrops also, because RFA, if there is hydrops, then it won't work so well because of the presence of fluid. Then of course the skill of the surgeon, the training and the skill and what you've learned, and that makes a difference too.
Definitely. So how do we follow these pregnancies after reduction? Dr. Rima?
Yes. So we need to follow, we need to confirm the cardiac activity of the fetus, check the fetal heart of the surviving twin. And another important thing is that we need to check the middle cerebral artery for development of any anemia because of the imbalance that happens due to the procedure. And of course, we really need to follow them up to weekly. And we always have this possibility of neurological damage in the surviving twin because of this blood that has been stopped, and which can cause damage to the other baby, the surviving twin. So we need to look for intracranial hemorrhage or cerebral injury by doing a MRI after 28 to 32 weeks.
So the procedure does not take away the complication of cerebral injury if one twin is getting reduced, because by the time when the procedure is happening, it may create, as like the twin we're reducing is dying, it creates an area of hypotension there, and blood may sort of shunt from the normal twin towards a dying twin, causing ischemia, and which can lead to neurological damage. And that can occur in up to almost 6 to 7% of the fetuses. So I think this is another thing we need to counsel them about when we're doing the procedure. So, Dr. Vanna, if you have all the three procedures, which one do you think is better? How does RFA and bipolar compare?
So I think the data out there generally suggests that RFA is the better method compared to the other methods. Bipolar cautery would have the highest risk of miscarriage, and RFA is seemingly is the best. But you have to compare the costs and the availability and in your own settings, like which modality you're comfortable with based on what is available. So all of that also comes into play. And I think in the earlier pregnancy, I would say RFA would be the procedure of choice if available. And towards the later part, it's of course because of the technicality of it, the bipolar cautery towards the third trimester would become the procedure of choice.
So yeah, I mean, they compare favorably as far as overall survival is concerned, but there's a higher risk of preterm premature rupture
of membrane.
Yes, and sometimes you cannot do it in very advanced gestation because of the bipolar we have has very, like the prong will only hold a cord around 15 millimeter thick. But RFA we can do a little later, but usually we do not do procedures beyond 26 weeks. So this was also our experience, and we found that interstitial laser performed the worst. So we don't do interstitial laser for fetal reduction. Now in monochorionic twins, we do only RFA. And this is also like it's like large number of reductions in monochorionic, in which again it shows that if you're doing interstitial laser, adverse outcome is higher, 60% compared to bipolar cord and radio frequency ablation. So what could be the other indications for doing selective fetal reduction in monochorionic twins?
So if you have a baby which is definitely anomalous, or you've done a diagnostic procedure and one of the babies is having a chromosomal abnormality, which is rare to happen because both of them seemingly should be the same. So if you have a discordant chromosomal study or a discordant genetic study, or in these special situations of monochorionic twins where you have a pump twin and a trap, the trap sequence where you have a acardic and a pump twin, or sometimes if you have a very advanced TTTS where you would want to sacrifice one twin for the other and just leave one. And in situations where you have DV reversals or a very discordant FGR where the Dopplers are fairly advanced, you're anticipating an imminent demise of one of the babies. So the smaller baby usually. So those would be the situations where you would go in and do a procedure like a interstitial laser or a RFA or a bipolar cautery to reduce one of the twins.
You have listed out all the indications. So like just to complete take-home messages and
So, yeah, I think it was an excellent panel, and I just want to say a few things that in multiple pregnancy, it is preferable that the invasive procedure should be carried out by a specialist who is also able to perform the selective termination, because all the time we have to be very sure, map them, label them, and be sure about the labeling. Then the choice of procedure and the timing depends on what is the chorionicity, what is the indication. And multifetal and selective fetal reduction can be performed in multiple pregnancies based on chorionicity, and that then we can decide the procedure. It is most essential to know the chorionicity for doing all the procedures, invasive procedures, whether they are invasive, prenatal diagnosis or therapeutic, and label them and label the samples. And the risks and complications and the post-test counseling should be done in detail for the couple.
I think we would conclude hoping that we have finished in time. So I'll just check if there are any questions.
Plenty of them, Dr. Vatsala.
Half of them you already answered the questions, and some suggestions were put in the chat box.
So Dr. Vatsala, by the time you are going through the questions, I can request Dr. Gujral to put in a few words, ma'am.
All right. See,
was-
the panel is excellent. I think nitty-gritties of procedures, pre, post care, everything has been discussed. I don't have to comment on that. But what I want to say is that to us obstetricians who are practicing high-risk pregnancies, we are the first point, even after a fetal medicine consult. The first question which comes to me as a patient comes and tells me, I have done the NIPT, why do you want to do this test? So I think you have to tell them that NIPT, though has reduced the invasive procedure, but is not an answer for all. There are certain many situations where the invasive procedure is required. Second question, the patient always asks, should I go for a CVS as explained with the fetal medicine or amnio? Now, how do you tell me the loss rate? Am I going to lose baby more with CVS or with us? Now, this is a very important thing. But I want to say that when we counsel, we don't have to go to the national, international loss rates. We have to tell them what is our loss rate, what is our experience. That is what the the specialist should say, that we've done so many procedures, I have this much of loss rate. We are parallel or not parallel to the international literature, that doesn't matter. And when you compare CVS and amnio, CVS versus amnio, it's an unfair comparison. I mean, you do a procedure at 12 weeks, and there would be some natural loss between 12, 16, 15 weeks, and you're comparing a procedure with that. So when you do a CVS, you have to keep in mind whether you say higher or lower, but tell them it's a very good procedure, advantages of early check, early thing that you don't see the baby, all those psychological aspects. But as you all said, confined placental mosism, failure rate, this all has to be taken care and it has to be done by experts. When you watch a procedure, once upon a time I used to do them myself. When I watch a procedure, CVS looks a little crude, the pushes, and amnio looks very simple, but I think CVS has its own thing. Now, regarding the second part of the fetal reduction, see, there are two terms. One is a multiple pregnancy reduction, which is MPR, and one is selective. Selective you have to do. There are so many indications, very beautifully said. Now, multiple pregnancy reduction, the triplets to twins, there is absolutely no doubt. Better rates, you all said, hypertension, diabetes, higher birth rates, you all said that. But twins to singleton, I think we should take with a pinch of salt. And when I read about all this, do you do, before reduction, you test the so-called normal fetus also? When you do an STs, fetal reduction for a, let's say, normalist baby you're doing, do you test the other baby also? It's very important thing, because if the patient asks you, is my other baby normal? So what are you going to do? It's a dilemma. Are you going to do CVS for the normal one also? If you want to reduce. So these are few issues which have to be discussed. And lastly, a lot of things that when you do a fetal reduction at an advanced stage, their alpha fetoprotein levels are going to be high. So please don't go and do a quad test and get a screen positive and get into the dilemma of things. Alpha fetoproteins are going to be high, very well mentioned. So there's no need to mention them. If you have any doubt, look at the ultrasound carefully for the CNS abnormality. And data on the twins is very clear. Twins versus singletons, all pregnancy complications are higher. Twins conceived naturally versus twins conceived by IVF. IVF twins have much, whether di, mono, anything, they have much higher complications than the natural conceived twins. So where does this lead to? This leads to only a single embryo transfer. That is what the IVF people should do, reduce the twins and maybe penalize this, you don't get so many complications. And we at Gangaram, we have been practicing single embryo transfers since 2015. And our twins rates have, remarkably gone down. Today, our twin rate is only 4% in the last year. So that's the message I want to give, that go for a single embryo transfer. Nothing more to say. Well, very well covered panel. Learned a few things. That's it.
Thank you so much, ma'am. Dr. Ashok Khuranan.
He said he was leaving. No, I don't know if he's on it.
And
no, he's very much here. This
very much here. Oh, you finished your work and came back.
Fascinating, yes. There is really, as Dr. Kamal Gujral said, there's not much to be added because we've covered up just about every piece of ground. But one piece of information for our members and for our attendees, that we actually have the Society of Fetal Medicine guidelines, which are now published guidelines, and they've been published in our recent edition of the Journal of Fetal Medicine. These are written by our own members, by people who are working on these on a daily basis in the Indian environment, and therefore contain a lot of information that is relevant, especially for beginners, but also for anybody who wants to mid-course try and improve their technique. So please do go through it. Most of the members would have received this copy of the journal electronically, and it's worth going through every piece of those guidelines. And a lot of the questions that have been asked in the panel here, in the meeting chat, are actually answered there as well. But I must appreciate the fact that we've put together this as a two-part webinar so that we can do justice to every bit of it. And my congratulations to Dr. Sangeeta Gupta for doing that for us. And so over now to the panel and everybody else for the questions that are lying waiting to be answered.
If Dr. Ratna is around, we could
Yeah,
ask.
I'm here. I'm here, Sangeeta.
Oh, nice, Dr. Ratna, please.
So I think just very, very simply, because you said like for a beginner, what is so essential when you're doing a procedure? And I think if I think of it in a very logical manner, it starts with the indication of the procedure. You always have to think, I think at the outset, we have to give a message. We are not here to identify everything. It doesn't matter. Even today, if I do every test in the fetus, I still tell them that there remains a background residual risk. I've seen patients where up to exomes are done in the antenatal period for an indication, very justified indication. But in the postnatal period, when we see the baby who has a problem, from that same data, I'm able to identify a genetic problem. So always remember, a data is analyzed based on what we see. And we can never, ever look at everything because there's so much which we get in an exome data. So I think that's the first thing which is becoming important for counseling, because it's not nice for patients to come back and say, well, we were told everything is being done and the baby will be absolutely normal. So I think that's one very important thing. The second thing is be justified for the indication. Don't try and do everything. And once all that is clear, you have to decide what is the best test to do, because I saw some questions, should we not do a karyotype before we reduce? How many procedures are you going to do? How much is the patient going to spend before, they are actually going to continue or discontinue a pregnancy? There are many things. Remember all the forms that have to be filled, the PCP and DT forms, the D, the E, the G as far as genetic goes, and I think F is for the ultrasound procedure. And after that, please liaise with the laboratory to whom you're sending a test, because everybody has their own way of doing an analysis. So if I'm doing an invasive test, say for beta thalassemia, I have to make sure that the mutations are known. I have to make sure that if a mutation has not been done in my lab, I always take the parent's blood to confirm the mutation at no charge. It's a part of my prenatal, because at the end, when I have to give a report of a fetus, I have to be sure from the laboratory side that I'm doing the right thing. And I don't believe in anybody else's report. And I think that's how every lab should work. Check for themselves that what they're doing is correct, because when you're doing a prenatal for a monogenic disorder, it's very important to make sure that things are right. But while I say that, remember it's a laboratory test, and we again have to counsel the family. It's the best that any lab is doing, but there's always a little chance of error, because it remains a chance of error no matter how careful the lab is. And the amount of sample, Dr. Seema covered that very well, but just very simply to put it, when you look at that tube, there should be at least the villi, the fonts that are floating about 5 to 7. All right. If it's less, if you give a less sample, the chance of error is more. So always remember that. If you feel you want to wait for a week, wait for a week. There's no hurry to catch the patient then and there, because it's in the best interest of the patient, and the patient comes back. So often we say that, no, right now it's not okay. Right now it's very thin. Come back after a week, because I don't want to receive a lesser quantity of sample. If we are doing amniotic fluid for monogenic disorders, for gene mutations, please do it after 17 weeks. At 16 weeks, The pellet we get, because we cannot use the fluid is centrifuged, the cells come in as a pellet, and the pellet we get is very small. So that will go into a culture and further delay cells. So that is the second thing. And so I think okay. The third thing, which I think is important, if you're transporting a sample, again, special media is used. We put a little bit of antibiotic into that media, but please liaise with the lab where you're sending the sample. It's usually a transport media, which is an RPMI media, because always your procedures are planned procedures. It's not, well, the patient has just walked in and let's quickly do the procedure. It's never like that. And when you fill a form for the laboratory, full information regarding the information of the test, the indication of the test, and if the mutation is known, the mutation must be written by the doctor who is asking for the test. Even though a photocopy of the mutation report is attached to the paper, but I'll give you a simple example why I insist on this. The reason is that there are two places, and if there is an error somewhere, it gets counter-checked. So sometimes that attached paper can get lost, something can happen. So all these things which are very small but very important and practical to take care of. I think that's all I have to add, unless there's one specific question that somebody would want to know about the genetics.
So thank you, Dr. Ratna. You've made our job much easier. We were about to discuss all this only in the next session. Nevertheless, when you speak, people do listen more carefully, and I think they'll keep all these points in mind. Dr. Vatsala, would you like to answer the questions in the chat box now?
I think we had by mistake signed out and then we again logged in. So I don't have the previous questions.
So shall I read out the questions?
The ones I have, I can read out for Dr. Ratna. For thalassemia, what gestation for amniocentesis? 16 weeks or 17? I think.
17, after 17.
17. So,
but can I just add something, Dr. Vatsala?
Sure,
that
sure.
If the patient has come in time, it's better to do a CVS because you get more material from a CVS. So if they come late, you can't help it. But if they come on time and you are able to do the procedure, it's preferred.
And I just wanted to add one more thing. Please let me know if I'm correct, Dr. Ratna and Dr. Vatsala, that it's better to do a CVS because if a selective reduction has to be done in multiple pregnancy, the fetal loss risk is lesser if it is done at an earlier gestation than late. Dr. Vatsala, do you agree with that?
Yes, true. And
So
I think also for like genetic tests where you're doing a molecular test, CVS gives you more DNA and you don't have to culture the cell. It is faster. And again, if you have to like do a selective fetal reduction, it's better because then you can do it early and the loss will be definitely less if you do it later beyond 14 weeks.
Yeah. So Dr. Vatsala, till what CRL can we do CVS in twins?
Twins, we have done like up to 14 weeks, but in singletons, we have done even at 24, 26 weeks, like a placental biopsy if the patients have come late.
And margin of placenta, this question even I can't figure out, marginal of placenta for CVS risk of bleeding high. I think we can just skip this question. Why NAPT?
So marginal means lower insertion.
Not really.
That should not really affect actually.
Yeah. I mean, margin placenta sometimes is a higher adverse outcome, but that's
only like a
just
couple
leave
of
it, just
times
leave it.
we have had patients who are like look like a
Yeah.
pup, you know, then I have deferred and done an amnio, I have not done a CVS for them.
All right. So why NAPT offered in twins with normal combined screening? Why not wait for amnio when CVS is difficult in twins? I think we have answered that question. Because earlier you do the CVS and if you have to do selective reduction,
It's easier.
less loss. When do we suspect placental mosaicism? So do we consult to do amnio when CVS comes positive?
think Dr.
It
Seema is
depends.
probably-
Yeah.
Yeah.
Confined placental mosaicism can only be, detected if you have done the amniocentesis. So this you cannot, tell. You have to tell this as a, this can be a, limitations if we are doing the CVS, because later on, suppose the baby turns out to be Down syndrome. So then probably it will be difficult for us to explain that why this has happened. So this 1% error rate of the confined placental mosaicism, that they need to know.
I think, Dr. Seema, that is a standard practice when you're offering CVS for aneuploidy to any patient. We always tell them that there is a possibility of confined placental mosaicism, and this will further require amniocentesis. If there is any mosaic report on CVS, you will have to do an amnio to confirm whether it is confined or it is a true mosaicism.
Yeah, but this all will be known after birth.
There you are.
Also, if it's a risk, if it's a risk for 13 and 18, it's better to wait for a amnio, because CPM because of these is commoner.
It's mom, correct.
But
Good
doctor,
point.
that's not
Especially if your scan is normal. Especially if your scan is normal.
normal. But what about 21? If there is a mosaicism on CVS for 21, then how do you proceed?
You will have to do an amnio. If the amnio is clear and there is no brown color because of maternal cells, and if that is normal, the chance for CPM is small, but as Dr. Seema said, it cannot be excluded.
All right. In multifetal reduction, till what gestational age can we do the procedure?
So I think you diagnosed your multifetals pretty early on. So if you've counseled them and clearly told them the risks, you should have done the procedure early on itself. Inadvertently missing the bot is could happen because the patient didn't have access to healthcare, or she was not counseled, and so on. So I don't think there's a set age there, but if you have a triplet pregnancy and the lady is 50 years old, she comes at 16 weeks, I think we still need to offer either houses open there, because we're not doing MTP. We're not taking out anything from the...
And also, at times when they come to you in the second trimester, when the risk of abortion is high, you can, I don't know how the law permits in our country, but generally there
But
are
you have to understand, the later you're doing the procedure, the more the risk.
Yeah. So I think in third trimester also people have attempted.
The later do the procedure.
I know there's some view that if you have to do a selective fetal reduction in twins, you may do it in the third trimester, 32 weeks, to avoid the risk of preterm birth. For selective fetal reduction.
Yeah, this was the next question. So anyway, you have already covered it. Is it better to check chromosomes in the singleton before reducing the monochorionic pair, as they won't have any biochemical screening in the first trimester?
If they're discordant, or if they are...
It has been mentioned. So probably they want to ask that if it is a monochorionic pair and one wants to reduce one of them, will you do a CVS for the next? I think, I don't know.
We generally do NIPT. I mean, this is twin only. If it is triplet, of course, we can't offer anything. But if it is a, monochorionic twin, then we generally offer them NIPT these days, because much of the, everything surrounds around trisomy 21 only for us, without any family history.
Why we can't produce cardiac tamponade by saline in monochorionic triplets for reduction?
No answer. I don't know. I'm not ready.
Vascular,
That will be similar to putting
Sorry?
It will be similar to putting in KCL. We're not doing vaso-occlusion. So
all right. Yes.
and it may still cause shunting out. It's
Is
not
it equally
KCL
effective?
will go to the other fetus, but there may be shunting of blood from the normal to the dying twin, as there is hypotension here.
Is there any different technique for RFA BCC in case of anterior placenta? I don't
try to avoid the placenta, but if it is anterior placenta and you have to do the procedure, you have to go through a thin part, and it can also lead to bleeding. Sometimes you may puncture a sinus and there may be intra-amniotic bleed.
All right.
So other complications that may happen.
Is there any gestational age cutoff which confers higher risk of neurological damage to surviving co-twin after one twin demise in monochorionic pregnancy?
Generally
I
beyond.
would say about 14 to 15 weeks. So if the demise is before that, the risk of neurological damage has not really been reported in literature. After 14, 15 weeks, it's been reported. And of course, higher we go in the gestation, the higher the risk of neurological damage.
Yeah. And if we are not able to reach the heart, can we put KCL in sac? I think then thorax.
Sac.
Thorax.
Thorax.
It is
Thorax.
a
Even in
sac.
the
Agreed.
brain, it would work.
No, it actually doesn't work. Mostly from the thorax, the KCL remains there. I've done that and seen that it doesn't work. The cardiac activity may go off, but it comes back after a minute when you see. So best is to, of course, go intracardiac.
course,
But in
best
very small fetuses, yes, we can put in the thorax probably some of the
When
absorption.
you're doing reduction for like sometimes they put it in live ectopics or cesarean scar ectopic when it is like 6-7 weeks, then you can't really go into the heart. So we put it in the thorax. But like if you're doing reduction around 12 to 14, we should be able to go into the heart and inject.
How to approach a case of monochorionic monoamniotic twin with one discord? I think we have discussed this. Dr. Ratna, this is a question specifically for you. NIPT can be done after how many weeks of fetal reduction? Reduction is done at 12 weeks as it takes long time for the fetal pole to disappear. Acha, Dr. Ratna.
Okay,
We
I
don't
can
know.
answer this.
Dr. Seema
So
can
there
answer.
yeah. So
Yeah,
know,
you
this is a-
can't. Oh, sorry, Seema, take it forward.
Yeah, please, ma'am, please. Go ahead.
It's a bad idea to do NIPT after fetal reduction. I think that's a simple message.
In triplet
So,
with
so the companies will say 8 weeks, but I think it's a bad idea.
Yeah.
We go
Very
by
nice.
whatever is
That's
available.
Absolutely, absolutely. Agree with you on that.
in triplet with monochorionic subset, if we reduce monochorionic and one of them survives, how do you counsel? Somebody has answered as well. I think reduce. No, I think it's a question. Reduced by KCL.
Yeah, you can reduce the leading twin. Like Dr. Vandana said, in the first trimester, the risk of neurological sequelae for the other twin is less, but still we cannot rule it out. So you can attempt again reduction.
Yeah. But if you are going to reduce both of the monochorionic in a triplet, then anyway you would be using KCL even in the first four. Then there is no question because we have to reduce both. So we can use KCL. Yeah.
Sometimes, ma'am, even in the monochorionic pair with one, the cardiac activity of the other does not go. So we have to
Yes.
reduce both of them and then
Yeah.
stop. Use KCL for both.
So isolated fetal exome, should it be a strict no without simultaneously parent exome? Are you coming across such? I think this question we can skip. We are here discussing invasive procedures. We are not discussing some specific genetic tests. Somebody has asked if we don't have time for prenatal mutation detection in thalassemia, is it mandatory to do parental mutation analysis?
It's mandatory.
Yeah.
Absolutely mandatory.
For patients with HR for high risk for trisomy 21 on dual, should we, I think we can skip this question. This is more of a genetic test rather than invasive. Ma'am, can microarray detect mosaicism or is FISH only is necessary to detect mosaicism?
FISH is the best test. You can count up to 100, 200 cells in FISH. And in a microarray, you're limited. It can only detect when it's about more than 20%.
Okay.
So microarray is not the test for mosaicism. That's the simple answer.
Okay. For reducing monochorionic pair in dichorionic triamniotic, do we prefer going in both hearts? Yeah, I think Dr. Reema has already answered that question. So I thank all my panelists, the moderators and the experts for this panel. Nevertheless, please don't leave us. Now we have something which is very elementary, but I think very essential. Doing an invasive procedure and collecting the sample is one part of the first part of the game. However, after collecting the sample, how to label the sample. Many of these things have already been covered in this panel, but Dr. Ranjana Mishra, who's a geneticist at Yashoda Hospital, Ghaziabad, and BL Kapoor is going to join me in a crosstalk about intricacies of handling a prenatal sample. So, Dr. Ranjana, welcome.
Good evening, ma'am. Good evening, everyone here. And we have almost covered most of the aspects of pre-analytical handling of these crucial samples. Nevertheless, we'll be touching, just to reiterate the importance of this pre-analytical handling, we'll be touching upon some very basic questions
Yes.
in this part of the webinar.
So, drawing the sample is a part, but ensuring that the sample reaches the lab properly and with correct information is a great responsibility of the person who's collecting the sample. So, Dr. Ranjana, my first question is, what do you expect when a sample of chorionic villus or an amniotic fluid uh, uh, is sent to you? What do you expect from the person who's going to send the sample? And what do you expect that the sample should be like?
Yeah, so ma'am, at the lab end, first of all, what we do is do a quick visual inspection of the samples received we look whether it's adequate or not. Like we have already discussed, for a chorionic villus sample, we should get at least 4 to 5 good fronts. And for an amniotic fluid, it should be, these are the minimum recommended amount, about 15 to 20 cc, preferably more. And check for any contamination with maternal, visually it is contaminated with maternal blood. Then I would see whether there is accompanying maternal sample also or not, which is important for doing the maternal cell contamination, checking at the molecular level.
This sample should be collected in the EDTA vial.
Yes. So this maternal sample should come in a EDTA vial, which is a purple top vial, and at least 3 to 4 cc of some maternal blood is required. And then I will check the clinical summary. Proper details should be there, along with including the clinical details regarding the obstetric history. The ultrasound features should be mentioned. I'll check all the forms, the test requisition form, then all the codal formalities, which includes the Form G, and Form E should be, that is to be filled from the lab side. And if there is any previously done genetic testing in any form, any workup of the previous child, like Ratna ma'am had already mentioned, if there is a mutation marked, that a photocopy of that report, a workup of parent, if a carrier testing of the parent has been done. So all this is very, very important for downstream analysis.
And I would just like to add a few things here, that whenever you are sending the, chorionic villus sampling, one should specify one thing very specifically: if the pregnancy is an IVF pregnancy by donor or surrogacy. We'll touch this point later again. And, whenever you take a prenatal sample, please make sure that you are in tandem with your geneticist. So genetic consult is very, very important before sending the samples, because that person can tell you what test has to be ordered and whether this sample will require DNA storage, and if yes, for how long. So genetic test consult should be taken before you send the sample, and again after your reports are there. And another important thing is, please be in tandem with your lab person as well. And your TRF, that is the test requisition form, should be very nicely filled with all the identification of the patient, name, the registration number. Then you should clearly mention the date of birth of the patient. And you should also write the contact details of the patient, her mobile and email, and your contact details as well. And the forms which are very important from the PCP and DT point of view are the F and G form from the person who's doing the invasive, and the person who is doing the invasive along with the TRF and the clinical summary, he should send a copy of the G form to the lab. So I think, Dr. Ranjana, we have completed that list from here. And Dr. Ranjana, the next issue is that, when you get a sample, sometimes there is lot of there's lot of decidual tissue in the sample. So from my end, what I can do to minimize the decidual tissue in the chorionic villus sample is that I try to take the sample closer to the fetal surface of the placenta when I'm doing a chorionic villus sampling, rather than being away from the, rather than being closer to the uterine surface of the placenta, because that will avoid the decidual tissue. So that's what, as an fetal medicine person, I do. What can you suggest? What do you do to decrease this decidual tissue in the sample?
So we at the lab, we again take the sample in a petri dish and examine it under a dissecting microscope, and we tease out the decidual tissue and separate the fronts, the villi, which can be easily identified as a thin villi-like structure. They are almost whitish, and they have branching pattern. So with a good dissection even at the gross level, you can very adequately, very nicely separate the decidua from the chorionics, the villus tissue. In the next step also, so this we have done at a gross level. At a microscopic at the molecular level also, maternal cell contamination can be ruled out. So what we do is this is a molecular testing. We use certain, like Seema Thakur ma'am had already, she touched upon this part, how we do it. They are very polymorphic markers. We call them STR markers. They are short tandem repeats on the DNA. So we extract DNA from the maternal blood, and the DNA has been extracted from the fetal tissue, that is the chorionic villus tissue, and we then match them based on these polymorphic markers. And then we can compare the two and conclude whether there is a contamination with the maternal tissue or not. So herein comes the role of the information regarding the whether this pregnancy has been conceived by a donor oocyte, or whether this is a surrogate mother who is carrying the fetus. Because if this is a situation, then there will not be the fetal tissue will not have matching with the maternal sample. So and the lab will be just caught off guard in case of mismatch. So this information, in case of, especially in IVF pregnancy, this information becomes very crucial for the lab for giving a conclusive report.
So, there are few things which are done to decrease the maternal cell contamination, like the area of the placenta which is sampled, and dissecting and separating the villi from the decidual tissue. And that is why a good lab will not accept any prenatal sample unless it accompanies the maternal blood in EDTA vial, because this maternal blood is very, very vital to do the maternal cell contamination. And as far as donor ovum or surrogacy is concerned, this maternal cell contamination check at molecular level becomes invalid. So that's where the importance of this information lies. So Dr. Ranjana, though Dr. Ratna had already talked about it, but do you want to make any comment on the media for collection of samples? See, in my practice, I know for the beginners, sometimes the beginners do ask for media in amniotic fluid. Amniocentesis also, let us be very clear that amniocentesis does not need any media. And can you talk about chorionic villi then?
Yeah, sure, ma'am. So here for you need media only for the chorionic villus sampling. Again, here it's always a good practice to contact the referring lab where you'll be sending the sample to know their requirements. Usually the labs, they have a requisite that the sample should be collected in their own media. So and if it is so, you should be able to procure that media beforehand. And they will provide you with the transport media. Here you can collect, and the transportation, if it is expected, that the sample would reach the lab within 24 hours, then it can be transported at the room temperature, that is the ambient temperature. However, if a delay is expected, then you should refrigerate the sample, but not freeze it. That means it should be transported in an ice pack, but this delay should not be beyond 72 hours. So that is why fetal medicine specialists should try avoiding doing these prenatal procedures on weekends where you may not be sure whether the sample would reach the lab, which is outstation, within 72 hours, or at least to have a good collaboration with the lab so that it timely reaches there.
And some of the precautions which people who are doing the procedures and dispatching the samples to be taken is that it should be, the samples should be, the vials of the sample should be very properly sealed. So, we can use paraffin tape to seal the samples, and they have to be labeled properly. So, one does many procedures in a day. It is a good practice that we should label the vials, and we should fill the forms before collection of the samples. And it should be doubly checked, that the identity of the patient should be doubly checked even at the time of sampling, and when you are going to put your sample into those vials after collection, you should have a look at the form, have a look at the vial, that yes, it has been labeled correctly. You're putting the sample of X patient into the vial which is labeled X, and there is no mixing of samples, because this can be disastrous. So, one should, I know that it's a teamwork, but nevertheless, one should personally check that yes, my sample is going, the name of the patient and the label on the sample is same. And we should try to keep our samples upright during transportation, and all the PRF forms and PCP and DT forms should be accompanying the samples. I think, Dr. Ranjana, the last question which we can discuss is, what is the DNA storage policy, and what do you have to talk about this?
So this is a very important piece of information here, ma'am, regarding this DNA storage policy. So most of the labs, what they do is that they take a portion, aliquot of the sample, the original sample, and keep it aside as a backup for any kind of second type of testing, or for DNA extraction. And the time period, at least for the time period during which the analysis is ongoing. Sometimes they do a store for say 3 to 6 months also. This time period again may vary. However, if the clinician, if the referring physician feels that an extended storage of the DNA is required, then it's always a good idea to let the lab know about this requirement. And this may come at an added cost, which should again be conveyed to the patient, because there is a cost also involved for extended DNA storage. And this becomes a necessity sometimes for doing the second line of testing, usually the DNA based testing for single gene disorders.
So I think even increased nuchal translucency, invasive procedures which are done for is a good example. The first test which you do on this kind of a sample is you check for aneuploidy. And if you don't have any aneuploidy, then you go for further DNA testing for rhizopathies or Nonans. And it may require further testing, stepwise testing. So
yes.
For that, the sample is there in the lab. However, there is no harm if there is any anticipation, then DNA. And for this, the genetic consult again is very important. Here again, the role of geneticist is very important, because the geneticist will guide us that whether the matter will be resolved by single testing, or we may need a stepwise testing in certain disorders. So I think with that, we conclude this crosstalk. I hope it has been a useful exercise. And my message to everybody after this crosstalk is that, this prenatal testing, in the prenatal testing, as a fetal medicine specialist, each and every invasive test which I perform, before I do the test, I always take a opinion of my geneticist, And whenever the reports come, despite the fact that I think over this 15 years of experience, I feel competent to interpret the reports, but I always send the patients back to my geneticist for having a consult. And Dr. Ranjana, you also must be having some key messages.
Sure, ma'am. So here, from my side, it's just that you have already reiterated this part that pre-test counseling, biogeneticist, post-test counseling is imperative. It's always a good idea to liaison with the lab because these samples are very critical, very crucial. They are not like ordering routine tests. What type of tests should be ordered? Any requirement for second line of testing? So for all this and even for quality check of your sample. So for each and every step, if you have a contact person in the lab, it will always work up in a beautiful way, and it will come. You will have greater satisfaction with your results. The satisfaction will be on both sides, for the fetal medicine person as well as for the lab, which is going to conduct the test and release the report.
So I think with that, we come to the end of this session. And I would, first of all, at the end, I would take the opportunity to thank Dr. Mohit Shah. He's the National President of Society of Fetal Medicine. And my sincere apologies for having missed him in the welcome note. And thank you so much, sir, for sparing your valuable time and joining us for this webinar. I also would like to thank all the experts and the faculty members for giving their valuable inputs, and definitely a lot of hard work has gone in preparing these sessions. My sincere thanks to the delegates who have joined in really great numbers. It was very encouraging to see that this topic was of great interest to all of you. My thanks to Vishal, who has always been the cornerstone of organizing these webinars, to Conferences International, who provide us this seamless platform, and to our sponsors, Lal Pathology Labs. And with that, I end the session. And I would like to invite Dr. Ashok Khurana to say a few words. I think probably he's not there. So I think we can take, oh, I'm so sorry. Where's Dr. Ratna? Ma'am, if you have anything to add for the crosstalk.
She has left.
Okay. Dr. Seema, if she's there, if she wants to add something about handling of samples.
She also left, ma'am.
Okay, then I think, ma'am, shall we call it a day?
Yeah, thank you, Sangeeta. Wonderful webinar. Thank you so much. And I say you make us all read. That's nice.
Thank you, ma'am.
Thank you, and a good night to everybody. Lovely interacting with you all again.
Thank you.
Good night. Good night, everyone.
Thank you.
Good night.